Let us start today's program. Today, the first speaker is Dr. Devdatta Mojumdar. He will be speaking on newer aspects in lipidology. So, may I request Devdatta to start sharing your screen and your deliberation.
Sir, are the slides visible?
It is visible.
Okay, sir. So, good evening, respected Guho sir. Good evening, respected Sauro sir. And good evening to all my friends. In regards to Dr. Subra Banerjee sir. It is really a pleasure on my part that I have been given the opportunity to speak on a very important and a very relevant topic, which is relevant in our day-to-day practice. That is newer trends in dyslipidemia management. The advantage of this webinar compared to others has been that Sir has given us the liberty to choose the topic and give our deliberation. Sir did not, choose the topic for us. Actually, I'm a bit fond of this particular topic, so that is the reason I chose this. Another reason I chose this topic was that I found there are a number of newer additions in the therapy of dyslipidemia management. So what I well know, because I know this is a group which comprises of all my teachers, senior cardiologists, my younger colleagues. So nothing is new, I can understand, but I thought it was worth reiterating what we already know, given the fact that there are certain newer aspects that is finding place in dyslipidemia management. And we all know that India is the capital of coronary artery disease, type 2 diabetes, also dyslipidemia. So it was more, I think, relevant that I speak on this topic. Thanks for the opportunity once again. So essentially, I know I have half an hour time, and I'll try to do justice to what I would actually say. The purview, to introduce the purview of my talk essentially would be from a concept of high intensity statin to a concept of high intensity lipid lowering. So intentionally, because obviously for want of time, and nothing per se is very new in statins. Statins is the king of dyslipidemia. It is very difficult to dethrone statin, given the fact that it has been there for the last 30-35 years. It has cemented its place in dyslipidemia management, but there is a lot of things beyond statin as well. So I essentially would try to speak on, revise, I would say, revisit the drugs which we already know and have a introspection of the newer drugs. I would certainly speak on these molecules, ezetimibe, this one, icosapentaethyl, the monoclonals, the antisense, the silencing RNAs, and ultimately gene editing. We are all aware, because this is the evolution of dyslipidemia management. From a daily tablet therapy, can we reduce reduce the frequency? The dosing would be more infrequent, and in turn I would get a more consistent benefit or effect. So from monthly, bi-monthly, maybe biannually, then annual, and then anything for life permanent solution. This is what I am trying to deal with in the next half an hour. What we all know, and nothing new to say, that LDL continues to remain as the main target of therapy. What is a co-primary target is a non-HDL cholesterol levels. We would like to see them together in the same breath. And certainly this is an old wine in a new bottle. We have this since 1963, but there's a renewed interest on this lipoprotein A molecule for adequate reasons. Yes, what we very well know, the apolipoprotein B family, which is nothing but a AB100 and the AB48, which is 48% weight that of ApoB100. When you speak of ApoB100, what comes to mind is the major ApoB 100 carrying lipoprotein is the LDL, 90% of which normally. Then we have ApoB100 in LPA. We also have it in VLDL. These triglyceride-rich lipoproteins will also be a focus of discussion. And we know that ApoB48 is a marker of chylomicrons and their remnants. So these are just the basics revisited once again. What we certainly know is chylomicron remnants, I was saying, is 48. These are classified under triglyceride-rich lipoproteins. VLDL, IDL, LDL, the metabolites of VLDL, I mean, are all having ApoB 100, including lipoprotein A. HDL is characterized with ApoA. So what we certainly know is non-HDL cholesterol, which is a secondary or a co-primary target, is TC minus HDL cholesterol, which is also a very, very important and emerging area, I mean, a target for prevention of ASCVD. And there's also a new concept of remnant cholesterol, may not be very new, but still total cholesterol minus HDL minus LDL cholesterol, which essentially would include, these VLDL, IDL, the remnant molecules, which is actually the remnant cholesterols. So essentially, the therapies of dyslipidemia, we have at our disposal a number of newer agents. Statins was always there; it will continue to dominate. I will speak few lines on bempedoic, ezetimibe, PCSK9 silencing, other agents if possible, if time permits. ApoC3 anti-angiopoietin like proteins type 3, type 4, type 5, or those things. We'll try to cover up as much as possible, and certainly a few lines on anti-LPA RNA therapeutics. So that, as we all certainly know, is I should spend a few lines on these evolving RNA therapeutic agents. That is the newer horizon as far as, the advancement of dyslipidemia management is concerned. So I thought I would also spend a few minutes on this one. This is the Lipid Association of India, LI guidelines 2000, and very recent guideline. And this is the patient at question which we all deal with in our day-to-day practice. One of the very high-risk patients. We'll speak of the risk categories: acute coronary syndrome. Divide these patients into 4 groups depending on whether whether it's statin, NAV, not on statin, low, moderate, high intensity, and statin intolerance. So group 1, group 2, group 3 essentially. So what you do is send a blood sample for the lipid profile, including LPA. We'll speak of LPA. And then either you start or you continue high intensity statin with ezetimibe on admission. And then on receiving the lipid profile report, look at your LDL goals, we will just discuss, and then try to add on therapies. We have already had HIS, I mean high intensity statin with ezetimibe. And then as the need be, certainly add PCSK9. I speak of this with a lot of importance. Yes, we also have bempedoic acid, not available though in our country. Bile acid sequestrants, not very commonly used. But these are the extra agents that we have at hand today to achieve an LDL goal of at times less than 30 in some selected patients. And then you keep on repeating the lipid profiles. 2 weeks, if it's at goal, you're fortunate, continue with your treatment. If it's not at goal, keep on adding one by one. That is the statement as far as the guideline is concerned. But I think we should also, this is very recent, 2021, but I think a refinement of this guideline as far as the initiating time of PCSK9 is something which merits attention. This one, a crowded slide, we know, but we are all aware of this. I would essentially try to highlight on this one. High-risk patient, very high-risk patient. More than 3 major atherosclerotic cardiovascular disease risk factors, which we very well know. And of these very high risk, pre-existing ASCVD, diabetes with risk factors, evidence of target organ damage, very, very important. This is also assuming increasing importance day by day, that is the familial, homozygous, as well as heterozygous hypercholesterolemia. We are getting few cases, obviously, in our practice. So these comprise the very high-risk patients, and this is even more important, the extreme ones. And extreme ones have been divided into 2 categories. Category A, which is existing coronary artery disease with more than 1 high-risk feature. These are the high-risk features. And this one, the ultimate one, the highest risk patient, which is a coronary artery disease with more than 1 very high risk features. So you already have ACAD plus more than 1 very high risk features, or in spite of a high intensity statin, you are having recurrent MIs, a patient who is having evidences of pan-vascular disease coupled with maybe hypercholesterolemia, the familial ones, those comprise the highest risk patients. So I would like to reiterate on these very, very important points. Our interest is to identify high risk, the very high risk, and the extreme risk, which is again divided into 2 categories, category A and category B. The reason that these patients have been classified or triaged in this fashion is because, as we all know, the extent of absolute risk reduction would be highest. Higher is the baseline risk. That is the principle. And we are see, this is the goal that we are speaking of now in India. In Europe, it is less than 40, but in India, it is less than 30. Which one? The highest risk group that we just mentioned, the category B, I would like to reiterate this one, this group. And the others, the very high risk and category A are less than 50. And we know we will add 30 plus with non-HDL cholesterol, things that we very well know. And high risk patients would be less than 70, but our interest is there. How did we dare to have a goal of as low as less than 30? That tells us that we've had a miracle as far as these new drugs are concerned, that's PCSK9. It is only possible that you set a target of 30 when you know you can achieve that target. And that is possible only with a combination of statins. Statins alone wouldn't have been able to do justice to this. So it's statin plus PCSK9 which have been able to reach a goal of less than 30. And that is the reason we are daring enough to have a goal of less than 30 in those very, very high risk category. That is a point of interest. Yes, what we certainly know, but worth reiterating again, one drug is not the enemy of the other. We know that they have to have, work in conjunction, harmony. So once you have PCSK, we have it with us. We have high intensity statin. We have ezetimibe. Look at the LDL cholesterol reduction to the tune of 100 almost. 85% reduction you are achieving with that. And as you reduce the number of drugs, the extent of lowering obviously reduces. So if you have a PCSK with high intensity, still to the tune of 75. If you have this one, I mean only PCSK, it is 60. Look at this green one. Without PCSK, just statin and high intensity statin and ezetimibe, it is still to the tune of 65. So this is another thing which is worth mentioning. And we know what is the definition of high intensity statin. Any LDL cholesterol reduction of more than 50 is what constitutes high intensity statin. So this slide is also a very important one, just to reiterate the importance of these drugs acting in conjunction, acting in harmony. So certainly I should speak on, because we've spared time with statins. Statins, for obvious reasons, is not featuring in my discussion. So I thought I should certainly spend a minute or two on this very, very important molecule known as PCSK9. We all know that, but still worth reiterating that it is a carrier molecule. Essentially, it carries these LDL cholesterol, I mean the LDL receptors, and carries them inside the hepatocyte for its degradation in the lysosomes. So if you have more PCSK9, you have less LDL receptors. And if you have less LDL receptors, less LDL can bind to the receptor for its internalization and catabolism. So what is the essence of LDL cholesterol lowering is that it is so important that we have to have adequate amount of LDL receptors here. And PCSK9 actually inhibits that. It metabolizes the LDL receptors. So obviously logic dictates that this is the molecule of the decade, I would say. All agents are being targeted at this, because if you inhibit this by varying means possible, you would increase the level of LDL receptors and thereby enhance the clearance of LDL cholesterol and reduce the plasma levels of LDL cholesterol. I certainly would spare time. I think before going to that, I did not have a slide intentionally of the the landmark studies that we had with one with evolocumab, which we well know, Fourier trial, and the other one with evolocumab, the Odyssey outcome trial. These are the two trials done in ASCVD established patients. I think Fourier enrolled 27,000 patients. This one, Odyssey, enrolled 18,000 patients. So a huge database, and certainly helped reduce the primary endpoint of myocardial infarct, unstable angina, ischemic stroke. So benefit was certainly proved beyond doubt. And it is only after that paved the way for PCSK9 therapy in our clinical practice. All of us are using it based on those two landmark trials. That essentially reminds me of the ARNI trial of paradigm heart failure, which paved the way for its use in clinical practice. And then we were daring enough to see whether ARNI can be initiated in hospital, during the hospital in ADHF patients in transition and pioneer. The same principle is being applied in this. So if you can, initiate evolocumab in the hospital stay, during hospital stay in a patient who's been admitted with ACS, and that was exactly what was done in this EVOPAC study, evolocumab 420 monthly and atorvastatin 40. Obviously, all trials of PCSK9 would have a background of statin. That goes without saying. And what are we trying to look at? We are trying to look at what is the degree of LDL cholesterol reduction in the acute phase of ACS at 4 weeks and 8 weeks. What is the level achieved at 4, and is it sustained at 8? Certainly, it was not designed to assess the correlation between LDL and CVD events, but we can understand that is the most vulnerable period in an ACS patient to prevent recurrent ACS is the first 1 month post ACS. That we would all agree. So what we certainly want is not the magnitude of reduction of LDL cholesterol, but a very rapid reduction of LDL cholesterol as early as maybe 7 days or maybe 2 weeks within that vulnerable period. That is what is being targeted in these two studies. One is EVOPAX, and what is shown here, that both the ACC goal and the ESC goals, see 95% of patients achieved that goal compared to 40% when you had evolocumab with statin. The same was demonstrated when in this particular study, EVAC study, same group of patients, that it is the certain same thing. The trial was not designed to correlate between CV events, but what was shown essentially is look at the reduction 60% at 7 days. Can you imagine that with a statin ezetimibe combination? We all know that statin ezetimibe would at least take 4 to 8 weeks time, and that would actually cover up the vulnerable period post ACS as far as recurrence of MI is concerned. That is the reason when I spoke of that LAI, the slide, I think with all these studies at hand, these are not large scale studies. I know it is still not in the guidelines, but I think we should ponder upon this fact that can we really load patients with statin along with PCSK9 in all ACS patients, especially in a country like ours, and more so in those typical very, very high risk category patients, because we know as far as the risk profile is concerned, all ACS patients don't behave alike. So that is what is coming out with these two newer studies, which I found worth mentioning. Yes, we also had studies. As far as imaging studies with these newer agents is concerned, we had OCT studies, we had IVA studies in the form of Glagov. They all wanted to show that either you are rendering this vulnerable plaque stable by increasing the total, the thin cap fibroathoroma thickness. That is what is being done with this. And we also had been able to show in Glagov that the plaque regression is happening when we followed the patients with IVA studies. So it goes beyond doubt that PCSK9 has certainly sharing with statin those pleiotropic benefits. The rapidity of LDL lowering is something which stands out with the PCSK9s compared to the HIS and ezetimibe. So I think these are the ones So who are the patients really? I think worth reiterating, who would actually benefit the most when you add PCSK9 over and above statin with or without ezetimibe? Recent ACS we all mentioned, this is the point of interest. And then we already mentioned, but still, clinically evident atherosclerotic cardiovascular disease coupled with diabetes, polyvascular, symptomatic PAD, recurrent MI, these patients, and certainly lipoprotein A. We will speak a few lines on lipoprotein A given the time that I have at hand. So obviously, worth mentioning that this is the only agent till now which is available with us, and the only agent which can reduce lipoprotein A in contrast to statins. Yes, let us a few lines on ezetimibe is worth mentioning. We know that it is a cholesterol absorption inhibitor in the brush border of the intestine. It is the second in line. After statin, this is the most commonly used second line drug as far as LDL cholesterol reduction is concerned. We are aware of the mechanism which involves inhibition of Niemann-Pick type C-like protein, which is there in the intestinal brush border. What essentially happens? Cholesterol absorption is inhibited, less goes to the liver. Hepatocytes sense that the cholesterol is coming less, so you overexpress LDL receptors, so more LDL is catabolized. Things which we well know. What is the dose? The only fixed dose of 10 milligrams. It has a modest LDL cholesterol reduction by 14%. The major landmark study which paved the way for its use, again very well known, is IMPROVE-IT. It was done with a moderate intensity statin, not a high intensity statin that we use today. Simvastatin is no longer used, that we very well know. We are all aware of the IMPROVE-IT results. We also had similar 2 small-scale trials with ezetimibe. One was the SHARP trial, which I'm not mentioning here. One was the ACAS trial, which was done in aortic stenosis patients. There was a concern of cancer death with ezetimibe in the small-scale study, but that notion was dispelled adequately when we reintrospected the IMPROVE-IT and found that this was a chance factor. So nothing related to cancer as far as ezetimibe is concerned. So what can we say here is atorvastatin 10 plus ezetimibe 10 is equal to 80 milligram atorvastatin alone. But yes, you are sparing the patient of this very high dose with its adverse effects, if at all. However, even after if I've used a high intensity statin to the extent of 80 milligram atorvastatin, still you can expect a 10% reduction if you had ezetimibe 10 milligrams along with that. So certainly a wonderful addition as far as with statin is concerned, and it's easier said than done. All patients cannot afford those injectable factors as far as PCSK9 is concerned. There are disadvantages to that PCSK9 also. So I think this is again worth reiterating. So all drugs aimed at lowering LDL cholesterol, be it statin, be it ezetimibe, be it PCSK9, we'll speak of the others as well. So you see, what happens is essentially if you reduce cholesterol by varying means, you essentially, the hepatocyte senses low intracellular cholesterol, and that upregulates the LDL cholesterol. This is the final common pathway. More LDL receptor upregulation, so more clearance of LDL from the hepatocyte. So what can be said at this juncture? that for us to have an adequate LDL cholesterol lowering, adequacy of LDL receptors is a must. So we are all aware of that typical very rare patient who is devoid of any LDL cholesterol receptors. So all these drugs, statin, ezetimibe, this one, others we are speaking of, all would prove to be futile. So if you have to ensure an adequate lowering of LDL cholesterol with the available means, it is so important that we have adequate amounts of LDL receptors. That holds the key really. So now, I think I should certainly spend, that was the intent of this, the talk, that sparing time from statins, I would, have more time with these newer, because this is a molecule, again, a very, very important concept of the next decade. We are well aware, I know we are well aware, but still I would certainly say that this is a double-stranded RNA, a short double-stranded RNA, which I'm speaking of silencing RNA or a single-stranded, short inhibitoring RNA. So siRNA is the one. So this is how we are actually, modulating RNA therapeutics. Double-stranded RNA goes into the hepatocyte. How does it go into the hepatocyte? You actually conjugate it with a N-acetyl galactosamine. That is important. This GalNAc is important because once you conjugate this, only the liver cells will recognize this, other cells won't. So you have a tissue specificity there. So it will enter into the hepatocyte. And then what will happen? There is a dicer, a splitting enzyme, which will split the RNA into two strands, sense strand, antisense strand. Sense strand will metabolize on its own. What will remain is the antisense strand. And then that will, in the cell bind to a argonaute protein. And this argonaute protein will what is called as RNA induced silencing complex. That will be formed. And what will that do? This RISC will actually tag itself to the mRNA of question. It will recognize the genome based on Watson-Crick pairing. So it will fix itself to the mRNA of question and thereby inhibit mRNA to protein synthesis, translation, because it induces a conformational change in the mRNA so that the mRNA could be cleaved. That is the essence of, this silencing RNA, and which is obviously worth mentioning. And a single dose is effective. The action stays for at least 6 months to 1 year. That is the reason it is spaced every 6 months or at times year also. So just to reiterate what I just said, that it is a double-stranded RNA. I'll speak why I am focusing on that double-stranded repeatedly. It is a GalNAc conjugated so that it is sensed by the hepatocytes alone, so that these drugs don't go to other cells. And then whatever is done, we said, ultimately you are inhibiting the synthesis of PCSK9. Remember, that was a monoclonal antibody which acts extracellularly. This is, the protein synthesis is inhibited, so it is intracellular. Basic difference between the two. That explains the dosage frequency between the MABs and this one, inclisiran, and rest is same. What is also reassuring that it is only metabolized by nucleases to shorter nucleotides. So this I won't say, but what is important is the renal excretion is very minimal, maybe 10-15%. No hepatic excretion. So what is important that even in renal dysfunction and in hepatic dysfunction, this is a safe alternative that you have. We spoke of this and this one. So what are the indications? Indications essentially are the same. It is a substitute for PCSK9. So again, that heterozygous familial hypercholesterolemia, I stress on the word heterozygous for the reason we said that statin, ezetimibe, PCSK all would rely on the presence of LDL receptors. Secondary prevention of ASCVD. So essentially the same indications. What is the dose? It is available in a vial of 300 milligrams. 16 is sodium and 284 is inclisiran. Initial dose would be spaced every 3 months, and then every 6 months you are going to do, inject the patient. At times, even yearly injection might suffice. Yes, the trial basis, you have the Orion series. Orion 4 is an ongoing trial which is trying to look at the cardiovascular mortality, morbidity. It's an ongoing trial. I think results will come in 2030, maybe even after that. What we already know, Orion 9 was done in heterozygous familial hypercholesterolemia. Orion 10 established ASCVD. Orion 11, risk factors of ASCVD. What was essentially found, look at the extent of LDL cholesterol lowering, all had background statins with them in varying amounts, moderate to high intensity statin, and 50% reduction of LDL cholesterol is what we achieved with this very, very important newer molecule. Still not available in the country, but I am hopeful that this will come very soon. More we have, so more can we offer. We can individualize our treatment according to the risk factors of the individual. Yes, a few lines deserve mention regarding this one. Again, not available, but this is another addition as far as LDL cholesterol lowering is concerned. I would come to this. We all know about HMG-CoA, conversion from acetyl-CoA to mevalonic acid. This is statins. Just go 2 steps backward, I mean upstream. Citrate to acetyl-CoA was, we read, was converted by the help of this enzyme is ATP citrate lyase, ACL. So this is where bempedoic acts. Almost the same pathway really. And the same story here. Decreased intracellular cholesterol sensed by the hepatocytes leads to an overexpression of LDL receptors, and rest of the things follow as we mentioned. So I think it is worth reiterating again and again, statin, ezetimibe, PCSK, inclisiran, bempedoic all rely on adequacy of LDL receptors. That is so important. So none of them would have a place in the management of that very rare patient, homozygous familial hypercholesterolemia, who is completely devoid of any LDL receptors. Sorry, this one. So again, see, this is the evidence base. We have 4 trials really: Clear Harmony, Clear Wisdom, Clear Serenity, Clear Outcome. So all these trials, what essentially they showed, yes, it is effective, it is safe, it has a modest LDL cholesterol lowering, and when you combine this one with ezetimibe, you tend to have a reduction of LDL cholesterol to the tune of 38%. And if you can combine atorva, ezetimibe, bempedoic, you have a reduction of around 60-65%. That is a huge amount. So efficacy and safety has been proved. Only issue is, look at the uric acid level and the creatinine before starting. So with all these, FDA had approved it in 2020. So who is the typical patient who is a candidate of bempedoic? That not so common, utterly statin intolerant patient. PCSK now 9 for reasons not available. I mean, patient doesn't want. So what you have at your disposal, bempedoic, ezetimibe, that combination. So that combination is also approved. That is the place which bempedoic enjoys. So I think it's worth reiterating what we already said, that bempedoic acid we mentioned inclisiran, we mentioned a few lines on evelicumab and aliricumab. What we did not mention still now is these newer agents. We will speak of that, at least to name them. Pelacarsen. So anything which is sen is an ASO. I'll just speak of that. And see, olpasiran. Siran is again inclisiran with siRNA, and this siran is for LPA we are going to discuss. And I think we should speak a few lines on this as well. So now come to another concept of RNA interference. What we said previously, silencing RNA, double-stranded RNA. This one, antisense oligonucleotide, is a single-stranded RNA. What it does, same delivery mechanism, go to the hepatocyte and attach yourself to the mRNA with that complementary base pairing and inhibit mRNA to protein synthesis translation. So this would be spaced every month, and that one, the silencing one, will be spaced every 6 months. That is the basic difference between what is an antisense oligonucleotide ASO and the siRNAs. So these are the 2 cornerstone of RNA interference which finds a place now in hypolipidemia management. So what it essentially does, this molecule, that ApoB, enjoys the center stage of all the atherogenic lipid molecule lipoproteins. So if you prevent ApoB, you don't have any VLDL, IDL, LDL, those things. So what I'm speaking of, essentially the same slide. What I'm speaking of, this drug, this is not new, I know, but still worth mentioning. It is a reserve drug, 2nd generation antisense ApoB. So once, and it's a toxic drug, I know. It's plagued by, the hepatic adverse effects, but still, in selected individuals, it can certainly result in a decreased production of atherogenic lipids, all of them who have ApoB 100 as well as ApoB 48. Now come to another one. This is also very well known. Again, a reserve drug, because these are patients who are devoid of LDL receptors. The conventional drugs won't work. So what will work? This is microsomal transfer triglyceride protein, MTTP. What it does, ApoB, 2 lipids, they will combine and form VLDL in the liver. And the same thing will happen in the enterocyte, chylomicron instead of VLDL, which we know. So if you can prevent this MTP, lipid droplets won't conjugate with ApoB 100. We just inhibited the synthesis of ApoB with mipomersen. Now is what we are trying to do is ApoB with lipid conjugation is inhibited by lobutapide. So again, a reserve drug. It's before that I'll go to this. Yes. So there has been small scale studies. What is the dose like? 5 milligram daily. You can go it up to 10 milligram and a maximum up to 60 milligram. Again, plagued with this liver toxicity. But who are the reserved patients? Again, the ones who do not have any LDL cholesterol receptors. So the conventional drugs won't work. This is a patient we are speaking of. And where should you fit in this lomitapide? Patients who are actually denying or refusing, easier said than done. LDL apheresis, few lines on that. I'll speak on liver transplant. So certainly that comes to the rescue. And when you have this lomitapide, the spacing of, even if you are doing an apheresis spacing can be achieved. So again, conjugate therapy. I think I should speak a line or two on LDL apheresis. We know nothing but extracorporeal removal of circulating all apolipoproteins. Who are the patients? Patients whose LDL cholesterol more than 200 and CAD, or non-CAD but LDL cholesterol is more than 300. So essentially those heterozygous, or more importantly, homozygous familial hypercholesterolemia patients. Look at the cost of it's not available in India, and we are Indians fortunate we don't have these patients frequently. Fortunate for us, because we can't afford 3,000 to 4,000 USDs per session. And the efficacy is obviously, with that amount of cost, you have to be efficacious. So 80% reduction, and which is long standing. Obviously 18 months we have a 38% reduction even after 18 months. Adverse effects are the same as like a hemodialysis adverse effects. You need to have a AV fistula. So patients might not be very willing to look at, accept this LDL apheresis. Fortunately for us, we don't have to do all these things. But yes, LDL apheresis is another treatment for LPA reduction, just to mention about that. So come to this, another newer agent. Again, a refractory patient, homozygous familial hypercholesterolemia. This was a trial, ELLIPSE trial. What it showed, and this is a new drug, evanacumab, again a monoclonal antibody, which has an effect on the non-LDL receptors. It acts via the VLDL, IDL receptors, and hence are very, very effective in patients who are completely devoid of null variant, means that no LDL receptor is present at all. And even then, this drug is effective in reducing the atherogenic lipoproteins, both the cholesterol as well as triglyceride. We'll speak of the picture just in a while. So what did that trial show? It showed that in this phase 3 trial, in homozygous patients, regardless of the degree of LDL receptor function, even if you didn't have a single LDL receptor, still significantly lowered LDL cholesterol. That is the reason I found this to be worth mentioning. So can we just quickly revise working mechanisms of the LDL ones? We spoke of meponam, mipomycin, inclisiran, lomitapide. We essentially spoke of all which would help me lower LDL cholesterol. So I think I should be going to quickly that triglyceride-rich lipoproteins. So what is the guideline again? So yes, optimal would be, we would love to have a TG of around 100. So again, this one again merits a lot of discussion, but still I'll try to manage 150 to 500. Your main target, as we all know, is again LDL cholesterol, and assess the ACVD risk. We do all possible non-drug measures, fat, diet reduction, alcohol, look at the secondary causes. And still, if your LDLs and all these are high, add statin and ezetimibe to first achieve LDL target. It is only after your LDL-C targets are achieved by the necessary drugs that you think of this, a very new agent, a relatively newer agent, omega-3 fatty acid. Fibrates come into the discussion only when your TGs are more than 500, because your primary aim now is to reduce the risk of pancreatitis and do whatever possible in patients having hypertriglyceridemia. And India is the capital, is a country of hypertriglyceridemia, given the increased incidence of metabolic syndrome, diabetes, and all obesity and all that. So if it's more than 100, we know the risk of pancreatitis. Again, the goal would be, so fibrates, omega, followed by statins. So we can't, leave aside the LDL cholesterol, regardless of whatever your TGs are. Sorry, this one. So I think this diagram, I think warrants mention, because when you speak, we spoke of LDL cholesterol metabolism, but now we are speaking of triglyceride metabolism in the form of lipoprotein lipase, which is endothelial. So this holds the key. When you have an increased activity of LPL, you're essentially cleaving these triglycerides to one molecule of glycerol and 3 molecules of 3 fatty acid. So we want more and more activity of LPL, but LPL is inhibited by these 3 agents: apolipoprotein C3, angiopoietin-like protein type 3, and type 4. On the other hand, apolipoprotein A4 is actually stimulating LPL. So what you want? You essentially want to inhibit these 3 reds and stimulate this green. So that is exactly what is done by, we just spoke of this new agent. Evanacumab is a monoclonal antibody towards this. So if you can inhibit this one, angiopoietin type 3 like protein, LPL would function more, and you will have more catabolism of triglyceride-rich lipoproteins. theoretically speaking, if you can stimulate this one, this A5, obviously the same result would be affected. So again, MAB we spoke, if time permits, we'll speak of these two SENs. They have written or both names same, it is not the same, might be a misprint. This is, I have taken this from ESC. This would be Vopanorsen, not Volanisorsen. Volanisorsen is specific for ApoC3. So this is something I thought is worth mentioning, that in trying to assess the risk, a lot has to, I know it's half an hour, but regarding ApoB, low LD, low non-HDL comes into the scenario only when the patient has high triglyceride. So otherwise, LDL, ApoB, non-HDL, they are all concordant. There will be a discordance as and when our triglycerides go on increasing. So identify low ApoB, low LDL, low non-HDL, because this is a lowest risk patient, and just make it high, high, high. This is the highest risk patient. I am interested to know this one. ApoB is high, LDL is low, and non-HDL is low. This is a discordant high risk. How to explain this? Obviously, this means this is more of a small dense LDL cholesterol. So small dense LDL cholesterol is causing a low, apparently low LDL, apparently low non-HDL, but a very high ApoB. That, indirectly tells you how important it is, if possible, to measure everything possible. Lipoprotein A, ApoB, non-HDL, LDL, so that you have a holistic approach to the entire lipid profile of the patient. I actually did not understand, frankly, this one. How is low ApoB, high HDLC possible? I think my teachers will throw some light on this. I frankly did not understand this discordant low risk one. Yes, another thing which is I thought worth mentioning is what would be the ApoB goals like? So in these very high risk patients where we said that the LDL goal was less than 50 and extreme high risk where we had dared to lower it even to the extent of 30, the ApoB goals would be likewise less than 65, less than 65, less than 50 here. If possible, if we can achieve these goals, especially this is more relevant when you have hypertriglyceridemia, diabetes, metabolic syndrome. These patients are more important when we have this entire thing. Yes, I think this is also worth mentioning. Beyond fibrate, can we have a more refined fibrate now? Certainly we can have it. A selective peroxisome proliferator activator receptor modulator alpha. What it essentially does is it will just extract the benefits of fibrates and remove the adverse effects of fibrates. So just have the benefits. So it is a much more refined drug than the conventional phenofibrate. So it is the first in class fibrate. What is the advantage? No drug-drug interaction. Interaction with statin is very safe. Very, very high, risk-benefit ratio is very, very favorable. And patients on statin, patients with compromised renal, liver, in all these patients, can you use this, a new drug which is known as fibrate, given the mechanism of action? I think this will summarize who are the patients who are candidates of this new drug. Type 2, India is the capital. So all the associates of type 2, diabetic retinopathy, metabolic syndrome, combined lipidemias, renal dysfunction, coronary heart disease, primary biliary cirrhosis, NAFH, combination with statin, what more do you want with this improved fibrate? And we have a trial which is ongoing. I think the result will come in May this year itself, a prominent trial, which is actually enrolling the highest group patients, diabetic patients, secondary prevention, primary prevention patients, and 10,000 odd patients, so a huge number that way. And what is the effect of fibrate on the, the primary endpoint? Is it really able to reduce MACE? I think a few lines deserves attention on omega-3 fatty acids. This is a perfect example of you go on trying, repeating, and finally you will succeed. I say this because we had ASCENT trial, we had VITAL trial, we had strength study. Strength for the reason it really employed a high dose, 4 grams per day. But we all know that all were combinations of EPA and DHA. And we understood that just having a 4 gram is not enough. You should have a refined variant of EPA alone. DHA was actually, nullifying the benefits of EPA. That is the reason ASCENT VITAL strength did not show benefit. What really showed benefit is this landmark study. That is this is the study which paved the way. We all know it. Reduce IT, where a highest dose of 4 milligrams per day, 2 grams BD dose, icosapent which is a refined ester of EPA alone. You don't have the confounding variable of DHA. So certainly you expected benefits as far as this is concerned. You expected benefit in the reduction of ischemic stroke, in the reduction of MI, but at the cost of increase in atrial fibrillation that we are aware of. I think I will manage atrial fibrillation if I really can, have a drug as far as triglyceride is concerned, reduction. Again, a few lines on this deserves mention really. LDL receptor, LDL particle, ApoB100, disulfide bonding, ApoA, small a, we know. We know that this Kringle, cysteine-rich domains, Kringle 4 is the point of interest. Homology with plasminogen and whatnot certainly is an emerging risk factor of ASCVD, so a risk factor of ischemic stroke, a risk factor of calcific aortic valve stenosis. So we are actually trying to look at it. As I said, it is an old wine in a new bottle. And now we can have a renewed interest on this for the reason because we have drugs which can help reduce LPA. And what is also important is, before I tell that, who are the ones who deserves LPA testing? All patients, all individuals deserve. All Indians deserve. This is my take, because it will not change with life. It will remain constant. Why not have a single measurement and see what is your degree? But these are patients, family history, first degree relative, hypercholesterolemia, those familial patients. And this is a very important one, that even if you are giving a high intensity statin and the LDL cholesterol is not reducing as you expect, this is a time you suspect that most likely you are dealing with an elevated LPA. Even the LI guidelines suggest it has to be more than 50 milligrams per DL. But again, a twist is everywhere in lipidology. If you have a milligram per DL, you are essentially measuring the non-atherogenic, I would say less atherogenic LPA, the ones with a larger size. So nanomole per liter should be the unit rather than milligram per DL. But those can be discussed when we can discuss. But LPA has a special importance, especially when you have these two new drugs. We said pelicarsen, which is a antisense, a silencing RNA. We said olpasiran. We are having studies with pelicarsen, this phase 3 Horizon outcome study, which will come out in 2024. So so before that, because I don't want to skip any important slides, as a very quick revision of hepatocyte, enterocyte, glycerol-free fatty acid combining to give TG. This is DGAT, and this is the this is a drug, pradigastat, which is not available. I didn't spend anything on this. TG, ApoB, rest we said, nipomarsen, domitapide, volanisorsen. You also have a LPL gene therapy now approved. This is the name here. So this DGAT and LPA is just opposite. DGAT is causing glycerol and FFA to conjugate to form TG, and LPL is just doing the opposite. It is cleaving TG to glycerol and FFA. So all these drugs I've tried to discuss as much as possible. This is an antisense oligonucleotide we just said against ApoC3, and if you inhibit ApoC3, you have more of LPL. So what we could see is reduced TG by 70%, especially in patients with those type 1 Fredrickson familial chylomicron syndromes. Conditional approval by European Medical Agency. It's not approved by US FDA. That's the reason why it's not approved. It's plagued with thrombocytopenia. Doesn't matter. Once we have these new drugs in place, we can always refine these drugs to come up with a better alternative. So now this is what just to save time, the pictorial representation of how volanisorsen act. We have already mentioned how an ASO act. It is the same here. And this is I think my last slide. And I think I'll ask my sir to give me 2 minutes extra to speak of this on this wonderful attempt to permanently edit your genome. What you're essentially doing, you're doing a clustered, repeat, regular interspaced, small palindromic repeats. What is the meaning of this? It means that you have a guide RNA and a Cas9. This is a molecular scissor, this one, Cas9. And what you're doing is guide RNA, Cas9 together, conjugate with GalNAc and inject into the liver. And what it will do, that guide RNA will again by base pairing identify your genome of interest. And here it is PCSK9. It will fix by Watson-Crick base pairing to that sequence which is coding for that PCSK. And that Cas9 will cut that sequence. So you are actually editing your DNA. What more can we want? So that your PCSK9 synthesis is inhibited for your lifetime. So it is targeted with an adeno-associated virus 8, and the target genome right now is PCSK9. This is a wonderful attempt to what is known as a genome editing, and I think that is the as far as the newer developments are concerned. It stops here. It stops in. We don't have anything more to offer. If you can permanently, edit your genome, what more can we want? So I think I would end my discussion. I tried, and it was a pleasure really to prepare more than present. And it was an honor to be presenting in front of my teachers and my esteemed colleagues. Thank you once again for the opportunity.
Thank you, Devdatta. Thank you very much. It was a very exhaustive discussion on newer aspects of lipidology. Many of us are not aware of some of these things, definitely. So it's a learning process. And I think, please unshare your screen.
Yes, sir. Stop share.
But actually, what you have discussed about this as the subject is the newer aspects of in lipidology. Many things are not being practiced as on now. So these are in the horizon. Perhaps in future these things will come up. But at the same time, there will be some questions and some comments about the present day affairs. What we should do today, particularly we need to keep in mind the perspective where you are practicing. We are practicing in India. So it is I think just it is a hypocrisy if I say that I will go for PCSK9 in all patients. This is a sheer exaggeration of facts, and it is an impractical thing. So let me open the discussion with a few, first one or two comments. You mentioned in the very beginning that any patients coming with an AMI on an ACS, you start high dose statin and ezetimibe. Is it there in the guideline that you start straight away with an statin plus ezetimibe?
No, sir, it is not. This was the recommendation of the Lipid Association of India. But the guidelines which we generally practice is certainly we load them with high intensity statin, mostly atorvastatin, in a dose of 40 and 80, and look at the lipid profile levels measured at as early as 4 weeks to 8 weeks time, and then see whether the patient has achieved goal. Fortunately, most of our patients, definitely a sizable portion of our patients, do achieve goal if compliance is ensured, tolerability is ensured, do achieve the goal that we want from them to achieve. Generally, we are satisfied in most patients of ACS if your LDL is less than 55. It is only in those very, very high risk category that we would want to have even a lesser, a greater lowering of LDL to 30. There we might, because now what we are practicing is a sequential addition of high intensity statin followed by ezetimibe, if not at goal, and if possibly PCSK9 in those.
What you mentioned there in your discussion, that part is very well taken, that sequentially how we go ahead with the reducing the LDL. But my point was very straightforward, that should we give statin plus ezetimibe to all our ACS patients? Because this one statement you made, I think we don't have evidences enough to go ahead with that. We should start with high dose, high intensity statin as we are doing, and if required, we go ahead with ezetimibe. And perhaps this is, even if this has come in the Lipid Association guideline, you say.
Sir, 2021.
I don't know how far it is acceptable, because no major guideline is advocating this thing. What is the opinion of others? Shubhra, your face is very well seen in my computer. So, you please.
Yeah, firstly, I must congratulate Devdatta. This is a very exhaustive and very informative talk that he gave. And it's a really educative. He covered a lot of things which I also know. But I think my question to him would be, yes, just doing in the lines of what Dr. Goa has already said. If you look at the Devinci study, and that shows that if you go by the ESC goal, which is not as stringent as the LI goal, still less than 50% would achieve the target for lipids. I know that LI has been really strict with the LDL goal and has really reduced it to 30, but from practical point of view in our country, where we do not have access to, because of many reasons, to PCSK9 for all patients, how effective we are going to be with that lie goal. It would be very frustrating, I believe. And it would be very few people would be able to get that goal. So
So
do you?
what I just, if you, with your permission, sir, what Lai had mentioned is, I think I'll go in line that it is not in all patients that we, all ACS that we are trying to achieve a goal of 30. Those very, very high risk, if we could identify and then stratify the risk benefit ratio, if possibly, all ACS won't be treated in the same line.
Absolutely.
Paradigm of maybe our shift in our.
No, my question is, even if you look at the LDL goal for those who are not at high risk, I mean, not at extremely high risk, it's still lower than the ESC goal.
Yeah.
ESC goal is 55, and their goal is even lower than that. So
Yes.
that's what I'm saying. I'm not talking about the extremely risk patient, but even in those patients who are otherwise considered as high risk, for example, those patients with established cardiovascular disease, and we get plenty of such patients. So how do we actually go ahead with them? I mean, even it's very difficult to get a goal of 55, and then with a LIGHTS goal which is going to be even lower than that. That could be a little bit difficult, but
that yes, PCSK9 has all those impediments. I don't think ezetimibe has any impediment for that matter. If we can really, and just a shift in our understanding or maybe how we practice, that if we can, from the onset, all ACSs are high risk, but still if we can subcategorize and identify those patients who would do better with an LDL goal of 50, 55, whatever, just a 5 difference, can't we add, but it's not in the guidelines still we accept, high intensity with ezetimibe, because certainly the reduction of LDL certainly has an incremental benefit. If we really can achieve goal in most of our patients, identifying them, who are the candidates, not in all patients as I mentioned.
Devdatta, what you are telling is partly true, I will say, but this is, I would rather say this is a wisdom-based medicine, not evidence-based medicine. That is a basic difference.
Accepted, sir.
This is a wisdom-based medicine because the wisdom says the lower the LDL, better the outcome. That everywhere in any segment you look at, lower if you can lower it more, you get more benefit. That is the philosophy. So I agree there, but ezetimibe is not that it is a drug without any adverse effects. Ezetimibe does have some adverse effects, some on liver, on GI tract, on the gallbladder. It has some adverse effects. So why should I go ahead with this without some evidence? That lies the issue. Because when the ARNI first came, many people started giving ARNI left and right, even if the LV ejection fraction is in and around 45 or 50, because that is some LV dysfunction and it will be beneficial. But the same question comes up, that becomes a wisdom based, that is never an evidence based. Shubha?
Yeah, I was just going to say, I think what Devdatta is saying is actually probably is going to come to a guideline sometime in near future.
Yeah, it can.
And this has been,
definitely,
especially in patients with acute coronary syndrome, we know that they have a high sort of a MACE rate in the initial period. So it makes sense. And this has been propagated by many international experts as well, that we should actually think about starting on a high dose and then de-escalating the treatment if necessary. And by high dose also with PCSK9, because PCSK9 has also been thought to have many pleiotropic effects which can benefit. Only problem is we do not still have a robust study which shows that there is outcome benefit. So once we get such a study, and if it shows that thing, I'm sure logic says what he says is absolutely right.
Yeah, that's why the terminology, this is wisdom based.
Yeah.
If it is proved in a clinical trial, in an RCT, obviously this will be the things of the future. No question on that. I have a few more issues, but before that, Uday has asked you, how will you address statin intolerance in a patient with post-PTCA? Patient can't afford PCSK9. That is one. And Shuchit has raised another issue. Is there any harm to reduce LDL to even below 30?
I'll first answer
one by one.
The first question first. what is apparently believed to be statin intolerance is more often than not a pseudostatin intolerance. I would go to any extent to prove it is really a true statin intolerance, and by that I mean that yet what defines statin intolerance, that we have to first say, is the patient having a significant elevation of CPK levels with muscle symptoms. Myalgia is not, to me, according to me, statin intolerance. Even if the patient has, I would like to de-escalate, reduce the dose, reduce the frequency, in the sense that instead of giving it daily, I would give it once every 2 days or maybe twice or thrice a week. That way, change the statin. If you're on Rosuva, go to Atorva, vice versa. De-escalate and then reinitiate once you are those ailments settle, because I will make an all-out attempt to preserve statin unless I'm compelled to do without it, because ezetimibe will never give me the benefit which statin will give me. And we are fortunate again in this regard that we rampantly prescribe these high intensity statins. Very, very infrequently do we actually get a true statin intolerant patient. So that really is not important.
So one issue here you should address in the same breath: any role of pitavastatin in this particular scenario?
Certainly there is, sir, because given the fact that it's a much safer statin. But frankly, I'm not aware whether pitavastatin is available. That I'm
pitavastatin is available.
I haven't given available. That I'm learning from you, sir. So if that is there, certainly I would prefer pitavastatin compared to. But obviously, the evidence base is with Rosuva and Atorva. I don't know how.
Hardly there is an evidence with pitavastatin. Some Japanese study is there, but it is not it doesn't have any robust evidence base. No question.
And Shuchi, as always, a tricky question, as always. So he tells me, my teachers are asking me not to reduce LDL levels to more than 50, and you're asking me whether it's safe to reduce it to even 20, 10. Do you want 0? But yes, when you look at Fourier study, there were some patients, roughly around 1,000 patients of 27,000 patients that achieved the LDL cholesterol of 7, mind you, and even that level you had incremental benefit. When we are born, we actually are born with a level of LDL cholesterol of roughly 20, 30. So there absolutely, and it has been said that if you have an LDL of 20, 25 is enough for your steroid and all those cholesterol requirements. So there's no harm actually in further lowering, but you have to have studies, document, just for the sake of lowering, don't lower. And sir will not allow me to lower for certain.
One comment on this: all our body cells, they have their own mechanism of manufacturing the cholesterol, which they need. So whatever cholesterol or LDL we find in the blood is a spillover. So if you can clean that thing, nothing happens. Nothing happens to the cells, nothing happens to the body. So all the LDL, and that's why in the 4-year study, with a single digit LDL, there was no adverse effects. With such a small group, it is difficult to say whether there is any incremental benefit, but incremental benefit could be observed even up to 15. Lowering even up to 15 or around that figure, I don't remember exactly. But there was no harm, even if the LDL was in a single digit. That proves this concept that the body manufactures its cholesterol in the intracellularly, and whatever LDL is outside is spillover after meeting the needs.
Wonderful, sir.
Devdatta, one more question.
Yes, sir.
Or comment, because I don't have any experience with this. That's why I'm asking you this question. Don't think that this is a question of examination. So say, regarding the bempedoic acid, do you feel a combination of bempedoic acid, high intensity statin and ezetimibe can achieve or will be a good combination for the future?
Yes, sir. I already mentioned, I mean in the talk that yes, PCSK9 with all its impediments, bempedoic acid 180 with statin, this one ezetimibe 10. As a study is ongoing with a 10 milligram only atorvastatin, extent of LDL cholesterol reduction was 65. So if we can add high intensity over that, I think even if you don't have PCSK9, the job would be done with just tablets. So certainly,
perhaps the reduction won't be that magnificent, only very great. That is simply because they are working, they are acting in the same chain. In the same chain, they are working. So, in the upstream, bempedoic acid is taken care of. Somewhat in the downstream, you are taking care of, it is being taken care of by the statins. So, if you increase the dose of statin very remarkably, as we do it in high intensity statin, 40 milligram rosuvastatin or 80 milligram atorvastatin, I think the reduction will not be that dramatic.
That is the reason, sir, I said atorvastatin 10 with bempedoic and azidotic job. Conversely, if bempedoic is only eligible, patients who are eligible for bempedoic are the ones whom we can't give statin. Otherwise, statin and ezetimibe will do the job.
So a combination of three, whether they're toxic, what is the side effects profile, that is not very clear.
Everything will.
That can be a combination for the future. I feel so, particularly so those who cannot tolerate high intensity statin. Any question from anybody? Any question, comment, anything from anybody? I find so many guys. Mani is there, Shumanto is there, Prayank is there, Kollan, anybody? This was a wonderful deliberation and very, very informative. Very, very informative.
Your blessings, sir, all because of your blessings.
No question of blessings. This is a wonderful thing. A good thing should be said good. A spade should be called a spade. Bashab or anybody, any question?
I have one question for you, Shantanuda. Because it's wisdom based. So do you think that, based on wisdom, not evidence, we should start taking high dose of statin and get our cholesterol down as soon as possible so that we do not develop atherosclerosis in future, or it doesn't progress if we have already developed it?
Sir, my honest confession is I do take 20 milligram rosuvastatin per day, and my LDL is in the tune of around in 40s.
How much?
40s, in 40s, 43, 40s.
40s.
And this I am taking for the last 3-4 years, or if not more.
So I think I should double the dose.
Please.
My 70s,
please.
But taking 20 milligrams.
Please. That is simply because I do have a number of risk factors. Including premature coronary artery disease. My father had an atrial infarct at the age of 53. So I am diabetic, hypertensive, dyslipidemic, and whatnot, obese with central obesity. And if you stratify an atherogenic dyslipidemia, which the doctor was emphasizing, small dense LDL, everything, you say I had that thing. But there is a very good way of knowing small dense LDL rather than assaying it directly by looking at the TG-HDL ratio. That gives you what is some good idea about the small dense LDL. Anyway, we had a very good and a lengthy discussion on this. Enjoyable, really enjoyable. Now let us try to enjoy a case. Rothin, you are ready?
Yeah, yes, sir.
So start sharing your screen and tell us about this unusual cardiogenic shock.
Okay. Good evening, everybody. Sir, after the elaborate discussion of Devduta, after a long time, I am hearing from him. In my EG years, I used to study when the Devduta was PGT in medicine. We used to attend his bedside classes. And a wonderful talk. Thank you, Devduta, for your nice presentation. And very informative. Many years later, I am hearing all these newer molecules. Just for my presentation, I am just saying this is a. I think it's a just informal presentation. It is going to be informal, and I wish to get participation from the Is it visible? Is my screen visible?
Your screen is visible. Make it in the
Okay.
full screen.
Okay,
More
okay,
there's
okay.
a
Video,
full
video,
screen, yeah.
Yeah,
video.
yes.
And
Is it okay?
yeah, this is okay now.
Okay, okay, sir. I'm starting. Sir,
Switch on your video, please. Sorry.
yeah. Uh,
Ratan,
is
you are not
this-
visible. Is there
is it
any?
okay?
This is okay, but you are not visible. Is there any problem with your connection?
No, I don't think so, sir. My slides are not visible.
Your slides are very well visible, but you are not visible.
There might be some connectivity issue, sir.
Okay, carry on.
Okay, sir. Sir, this is just a small story. The case is somewhat very unusual type of presentation, unusual type of case. I think few of us have seen this kind of patient. This is a 65-year-old gentleman who is a smoker, non-diabetic, non-hypertensive, who presented to the emergency about 1 hour duration of chest pain, which was severe, with a incidence of one episode of syncope. On admission, at the time of presentation, he was having a blood pressure of 70/50 and heart rate of 48. However, he was having a normal saturation with normal chest sounds. This was the ECG at the time of presentation. The upper one was at the time of presentation in the emergency, and the lower one was he brought with him, which was recorded outside the hospital, which there was some evidence of AV dissociation. So I will stop for a while and ask the participants to have a discussion regarding on this thing, because at the patient presented with a shocked state. So I just wanted some comment from my colleagues, my juniors and friends, if just to have a insight into the localization of this particular culprit artery. I think Priyank, Mani, all my juniors are there. If somebody can just
proximal dominant RCA looks like.
why are you saying is proximal? RCA is okay, fine.
Proximal, there is evidence of AV dissociation. Patient was in shock. There might be a RV infarct as well.
But ECG wise, how can we say it?
ECG wise, there is an elevation in lead 3 which is more than in lead 2 and AVF.
Yeah, that goes in favor of RCA.
Yeah, that goes in favor of RCA.
Yeah.
And then AV dissociation along with hypotension, probable RVMI suggest proximal RCA involvement.
The
Okay.
Frank RV MI evidence is not there. V1 you look
V1.
at.
Yeah.
No, ECG wise,
it
ECG wise it is not there, but the presence of
ECG wise
hypotension.
I am talking. Let us talk about ECG wise. That is
I am giving the whole picture now. Patient present hypotension.
that can be. Of course, it is not 100% proof. I know.
Yeah. Thank you, Frank, for your comment. So now we'll go to this is the angiogram. So this was the patient was in shock state, so I straightaway went for femoral, and most of the time I go for just other coronaries before going to the plasty. I was also anticipating lesion in the RCA, which may be distal or proximal, whatever, but RCA is the IRA as far as ECG was concerned. So this was the left shoot. So you can see other views. There is a lesion in the proximal LAD, and Sark is deceased. And this is the RCA. So I will stop for a while here also. So any comment on this? So this was the RCA, which was showing a tight lesion in the mid part, I think. Yeah. So as per the clinical, because the case is like this, it's a atypical one. I will just have some interaction on this thing also, because I was thinking of this. This is to be the IRA. The patient was in shock, in a not that good state. And the angiogram was performed about within half an hour of arrival in the
A
hospital.
comment from anybody,
Yes, I think, sir, I can come in.
please. Anybody?
So I think from the ECG also, Rotin, you will agree that the fact that AVR was a bit down, and as sir said, V1 is also down. I was also thinking in terms of proximate RCA. And suddenly you have a triple vessel disease here. If you show the angiogram on the left shoot once again. Yes, you have a significant proximal LAD lesion. You also have OM, you have LCX. RCA is dominant here. So the patient is a triple vessel disease patient. I just missed out whether the patient is a diabetic, smoker, hypertensive, those things, those additional risk factors that we take into account. But certainly the clinical picture is out of proportion to the extent of coronary artery disease. We have even, more severe disease of coronary artery, and yet the patients are hemodynamically stable. A mid RCA, which is recanalized, 90% lesion. But still, I think I would be in favor of addressing the RCA, and in the same hospital setting, a staged PTCA, if possible, to that LAD. I won't do anything with that circumflex, frankly. First, I would address the RCA, and then maybe a staged PTCA to the proximal LAD. That is, I think, what I would essentially do. From the angio, it seems that the patient is a diabetic plus minus smoker. If given the opportunity, LAD, I will do a imaging. Maybe IVUS, which I am really fond of. Most patients, I try and do it with IVUS guidance. And RCA, I'm going to, fix RCA in this setting. Keeping in mind the hemodynamics, if possible, if you want an IABP, this one can be given. Maybe inotrope itself can elevate your BP, those things. Normally, so when we do an RCA, we actually prophylactically only start a NORAD infusion so that, don't disturb with that BP and all. I'm satisfied with the BP, and then you keep on doing your work. That is my take.
Okay.
Any other view? Mani, Shumanto?
Yes, sir.
Shuchit, anybody?
I think
Rochinda,
the clinical picture.
patient had 2:1 AV block. So
Yeah.
why didn't we put the temporary? So
Just see. Because at the time of presentation, the patient brought the lower bottom, the lower ECG the patient had before arrival in the ear. So there was the evidence of 2:1 AV dissociation, but at the time of presentation in the ear, there was 2:1 AV block. The patient had one history of syncopes that may be due to complete heart block or some other arrhythmia. I don't know. It cannot be said. But at the patient was having a heart rate around 50. I just, you can see the imaging. Yeah, you can see the in the lower part, the temporary is kept in the IVC. So I was just trying not to put a damage to the.
Okay, what about Mani? You are telling something?
Yeah, I was just telling, sir, that the clinical picture, the ECG and the angio is quite concordant. I don't find any discrepancy between these three findings, because if you have a multivessel disease, then even a mid-RCA lesion, a recanalized mid-RCA can produce such hypotension. And a very important issue is already raised, that I think temporary should be placed in, and it should be paced at a rate around 80, because that can increase your blood pressure. Because often we find, because of the bradycardia, the systolic blood pressure goes down to 70 or 80. Yeah, so in such cases, I always keep a high rate throughout the procedure, and that often increases the blood pressure also. And I think, as Devdatta was telling, that you have to you have to work with the RCA first, and if the patient is stable, maybe after a few days on a second sitting, you should do the LAD.
One point, sir. Suchi speaking.
Please.
I just wanted to tell Priyank. Priyank told that it is proximal RCA because we have an AV dissociation. Now, there is no relation of AV dissociation to a proximal RCA lesion. Even a distal RCA lesion can have an AV dissociation because
No,
AV
sir. I was saying I was saying proximal RCA because I suspected RV infection.
Okay, but that has no relation with AV dissociation as such.
Yeah.
That is the point.
That's it. That's it. I got it.
Okay.
And another thing is that even if the patient is having a distal RCA lesion, in addition to AV block, the reason for hypotension may be the vagal reaction. I think that way hypotension, in addition to other RV infarct, there may be other possibility of having hypotension in inferior.
Yeah, that can happen. That can jolly well happen because of the parasympathetic overactivity. That is possible. Okay, let
So
us
what was the
proceed.
ejection fraction, Rathinda?
Ejection fraction was around 50.
Around 50 before the procedure. I mean, in the emergency.
Yeah, before the procedure.
What was the
So
RV
you could
function?
have tried some fluids also.
The fluid should be given then.
Yeah. That's it.
Yeah.
Everybody presenting with inferior MI having a hypotension, fluid, IV fluid is always it used to be given in a jet.
No, because LAD was also involved. So maybe if the AV function was too much reduced, you could not have given fluids. But since it was around 50% in such scenario, keeping a temporary and giving some fluids, maybe I think the BP would have got elevated.
Right.
Yeah.
Did patient responded to IV fluids?
Yeah, to some extent the BP was elevated with IV fluid and NORAD. That was the sufficient thing.
If patient responded nicely to IV fluids, you can leave the patient as such without vascularizing any of the arteries.
Yeah.
And the patient for CABG later on.
And regarding the use of temporary, as Mani was saying, it may be personal choice, but I most of the time try to avoid put a temporary in the RV in the background of inferior MI because I might be injuring the infected RV. That may be a reason for perforation. So
I will also like to avoid the pacing in a patient who is otherwise stable. And if the patient responded well to IV fluids and the patient's heart rate is responding otherwise, we can probably avoid TPI.
Nothing, did you give atropine?
Yeah. Definitely. Atropine is always given in this situation in the emergency as well. You can see the image. The heartbeat is not that bad. I think at the time of doing the angiogram, the AV block was coming intermittently, and it was responding to medications only, not requiring temporary pacing. So should I proceed?
Please.
So I just thought, okay, this is the IRA. Let's have a dilatation. As the thrombus was not that big, I most of the time I try to balloon it. After ballooning, I put one stent. It was 3 into 33, then 3.5 into 223, I think. This was the result. And after that, the patient was in a good hemodynamic state and not requiring any temporary, and patient was apparently okay. So should we? This was the post PTCA angiogram. So now,
what is the time gap between the onset of the chest pain and your intervention?
It was almost 1.5 hours because the presented
1.5 hours.
Yeah, 1.5 hours. Yeah,
that's good.
Patient was just residing nearby, and it arrived at the hospital 1 hour, and it was half an hour delay from the ER to cath lab. So this was the ECG. So
you are fortunate that you have patients of MI residing next door.
Now, why I'm asking this thing is practically the overt evidence of infarct could be aborted There is a very small queue in 3 and AVF.
Yeah.
So I would rather say they did a good job.
Yeah. And now, say as per the initial angiogram, so there may be some options for sending the patient for bypass or doing a second, as Devduta was saying, that a second pre-discharge angioplasty to the LAD or in the second sitting can be planned. So I just went for the second, the patient was discharged, and after a couple of weeks, the patient came back. So now see. This is one view. So this is the magic. What happened?
Did you give PCSK9?
Yeah, that kind of thing. So
gene modification.
So at the time, this is almost 3-4 years back. I did this job, and at that time, Dr. Leela was there, Dr. Sunil Leela. He was so excited. So I will take the patient to ESC, and I present there. This kind of thing.
Can it be vasospasm, this thing initial?
Sorry?
Can it be vasospasm or something because the patient was in shock and all these things I'm just telling?
Do you find any other explanation for this thing? Do you know?
No.
That's the thing. A patient having a 2 year later this kind of angiographic changes. I don't think anything other than vasospasm can explain this thing. So
just coming in, just that is the reason, maybe just to take it from your case, that in all patients of PCI, when we engage the guide, I think it is wise to give a shot of GTN and then decide to do it for the RCA. But I do it for the left system as well. Put a shot of GTN and yes, take a reshoot, see what is there. And then
I was thinking that way also. But a patient having a 70 blood pressure and okay, that recovered with a high fluid, but I retrospectively I was thinking that that should be the one that in that way one should think that
give GTN in your particular in that patient. I'm telling in on other patients, it's better to have a practice of when you do an elective PCI. That is the first shot of the GTN and then continue with the not in your patients. Certainly.
Yeah. Can the RCA be also vasospasm that time?
Yeah, that's the thing, because
means it can be a diffuse vasospasm due to some vasospastic thing we have seen something, or means
just
yeah, am I treated with diltiazem now?
Oh, just a second. What is it?
Sir is muted. Sir, you unmute.
What are you doing now?
Sorry.
I
had a telephone. I
Take
just
the stand
had to
out
take
from
a
us,
telephone call.
Is my slides visible?
Yeah, but an unusual case. I'm seeing the first slide.
Okay. Just. Now you can see the right one. As Sujit was saying, that RCA. Now look at the RCA, which was present, which was at the time of PCI. This was the RCA. So now I was just retrospectively looking at this RCA. Where is the thrombus?
I think it is not very, I will ask the opinion of sir and others as well. It is not very common to have a vasospasm in mid RCA. We generally tend to have vasospasm in osteoproximal. Most
No.
cases.
Yeah. That's
Vasospasm.
after hooking the RCA, you get the attachment that there is a hooking site spasm is known to occur. The proximal part of the RCA. But okay, go ahead with the just look at the ballooning shots. I have ballooned the mid part. Okay, it's a long segment. After that, you should see the shot. So what is happening in the proximal part?
This is whole.
Now,
Proximal part, just go to the previous shot.
Yeah.
This one.
This one, okay, yes, I'm playing. The it cannot be plaque shift or spasm. Proximal part of the RC is disease free apparently, but after ballooning, it is there is a lesion in the proximal part also.
It can't be plaque shift.
Yes, I was also thinking that.
Now show the after ballooning that shot. Next one. The entire thing has changed totally. So can it be only spasm?
Yeah. Retrospectively, that is the whole thing, because such a bad type of LAD is getting. You can see this. So look at the changes in the LAD. So similar thing is likely to occur in the RC also.
Baffling, totally. Not only LAD is circumflex everywhere.
Yes, yeah. So
vasospastic angina also usually involves the RCA, no? Commonly, that ST elevation.
As far as I have gone to the literature, I have found such a bad presentation of vasospastic angina. I have found only 5 or 6 case reports. This is one. Here the patient presented with a VF in ear, and thereafter required multivessel plasty. And some patient, this patient was having a pre-operative angiogram showing an intermediate lesion, and after just before the elective surgery for the stomach, he suddenly developed cardiac shock, and the patient required only GTN injection, and that the patient the spasm gone and didn't require an angioplasty. This is one patient who presented with asthma, and there were some STD changes, and thereafter the patient once developed in-hospital cardiogenic shock and recurrent VF and requiring angioplasty for the LAD lesion, and thereafter when they understood that the patient was having recurrent chest pain, they checked they had gone for a second angiogram or second plasty, and they found that everything is gone. So this kind of coming and going situations, there are 4 or 5 case reports are similar like this thing, and most of the patient who presented for the first time in this way required angioplasty, and one patient was to be sent was likely to be sent just waiting for the elective CABG for left-sided lesion, just like my case. The patient presented with inferior MI, and RCA plasty was done, and patient was being sent for CABG just the patient was having recurrent chest pain. For that, a check angiogram was done to see the stent is okay or not. At that time, the left system was also seen, and the lesion was absolutely was gone. So this is the this type of this type of case. I don't think many will us will get in lifetime. And the patient has just a few weeks back he came with a 4-year follow-up, and I had done one halter for seeing whether some asymptomatic elevation of ST segment is occurring or not in the first after 1 or 2 months of primary, but it didn't. It was okay, and presently the patient is absolutely symptom free. Just he's saying that he has quit smoking, and he's presently and with diltiazem and nitrate, he is absolutely okay. So,
I think
okay, sir, there was follow.
I think two things come out from your discussion. One, it re-emphasizes our concept of doing just the IRA for whatever is there on the other system. We don't know that. That is one. So we could have saved stents like you did in your case. And two, if you are dealing with a flowing artery in a patient of MI, I think it again warrants GTN infusion like we do in elective patients, because it's easy to counteract the hypotension associated with a GTN. It's a transient phenomenon only. So routinely, can we inject a GTN shot in primary PCI if it's a flowing artery, because then only the concept of vasospasm can be uncovered. But I'm not sure whether this vasospasm can be long-standing as well. You give 1 or 2 shots of GTN, the vasospasm doesn't go off. You will be compelled to do a PTCA there.
Yeah.
Because it takes time to revert also. I am interested to know whether this patient complained of recurrent angina prior to. Did you take history of vasospastic angina, whether the patient had, or this was your first presentation of vasospasm?
No, the patient had some history of non-specific atypical type of chest pain, because he was a smoker. No definite typical angina was there, as can be predicted, as can be assumed, that as there was no fixed obstruction type of thing. Only the apparently normal or minor plaque was there. And
Rochin, was there any atypical chest pain, atypical angina? Because this patient is unlikely to have if it is a vasospastic one, very unlikely to have the foot angina sort of a thing.
Yeah. That's it. Because the patient was a smoker, he used to he didn't get any consultation for this thing. On just asking whether he was having some symptom, he was just saying the atypical side of chest pain. There's no classical angina, so that kind of presentation was there. But having a syncope with chest pain, this sort of emergency presentation is just for the first time.
Vasospastic ones, but even Prince metal ones, producing a prolonged spasm, even going into infarct, is well documented. There are several case reports showing that, and you have also shown some.
Yeah.
But whole issue is so the presentation can be explained. What is very difficult to find out from the angiogram whether this is a one thing one could have thought of, that is is there any more slides?
No, sir.
Unshare this, please unshare this.
Okay. There is a take-home message. This is vasospasm can present with this thing, and optimal management is not known, as the presentation is quite rare, and it may sometimes require life-threatening,
life-saving angioplasty, right?
Life-saving. Yeah. Well, that's fine. That's kind of, because one such case presentation was one such case report is there where the patient was refractory to
all the drugs.
Yeah. All the verapamil and
you need to make it a metal jacket then.
Yeah. That's it.
All the 3 arteries are big stents, at least in the proximal part, so that there won't be any spasm. This is perhaps can be the answer.
Yeah.
Unshare the screen. Unshare the screen.
Yes, sir. Just unshare.
What was the BP when you took the patient to the lab? Was it very low? Can it be shock-induced vasospasm that time? I'm just asking. One of the possibility.
Good.
Yeah, but that is one possibility definitely, because on patient who are on high dose of inotropes can have some effect on the coronaries as well, to have some spasm in the all three territories. But the patient had elevation from the very beginning, so that itself implies that there was problem in the coronaries from very beginning, and thereafter the drugs, that is inotropes and other things, were given. So it is unlikely to be with this the drug-induced things.
Another point which was surprising in this patient routine was that somehow patient baffles us even without, because most patients that we encounter don't have vasospasm. It's not very common, as you said.
Yeah.
Still, when you engage, when I do an angiogram and engage the RCA, there are times when you have a proximal vasospasm, and then we, as usual, put a GTN and all that.
Yeah.
So see here in your patient, even when you engage the guide, given the fact you have a mid-segment vasospasm and you don't have a guide-induced proximal RCA vasospasm, that again is acquired. You have it naturally. It's so difficult to explain.
Yes. That's definitely because retrospectively, when I see the angiograms, I also appreciate your point that there was no that definite spasm in the proximal part. Okay, this is one thing which kept me puzzled for a few weeks after that event.
Are you still puzzled today?
Sorry?
Are you still puzzled today?
No.
We are all puzzled.
Your puzzle has ended, our puzzle has begun.
He has shared his puzzle status with all of us. No, I have a point to make. See, this is really very uncommon, wonderful case. Now, it is, to me, it is almost impossible to suspect even a vasospasm in such a RCA when you are taking the patient for a primary, the patient presenting with shock, cardiogenic shock, and having 2:1 heart block or CHB, and then you find such a lesion in RCA and you suspect, and then you start an GTN infusion and wait for the vasospasm to go. This is almost very impractical in such 90 minutes of door to balloon time. So I mean, unless with a small GTN shot it is going and it is completely the vasospasm goes off. But once you have dilated with a balloon, and you have to put in something, because you have pre-dilated the entire length of proximal to mid RCA. And then if you still diagnose retrospectively, as you were showing, that now after the balloon dilatation, I could think of RCA vasospasm, but still you have to put in something because you have already dilated. Now, my only point is, if you really suspect vasospasm or somehow you find vasospasm, suppose you have seen such a lesion and you give a small dose of GTN or something and the vasospasm goes off. Still, before you are diagnosing it as a vasospasm and leaving the patient without stenting, I think some imaging should be done, because vasospasm very often occurs on a pre-existing lesion. I mean, whenever there is a pre-existing long segment lesion, maybe the vasospasm is superimposed on that. So just diagnosing it and leaving it away, I think there should be an imaging, and by that logic, there should be some imaging in the LAD also, because that was a prox LAD significantly looking lesion. And obviously it has gone off, but probably maybe there is some lesion with a positive remodeling, because of that you are not finding a luminal stenosis. So that is one thing I want your comments, sir, and all my colleagues.
Before sir comments, can I come in, sir, with your permission?
Sure.
Yes, true, Bunny, as you said. But see, even if you looking at the proximal LAD, even if you do an IVAS oblique OCT, I don't think that will guide you towards intervention. I think if you would want to really decide whether you would go on ahead with your intervention in LAD, I think an FFR would do a job better, rather than anatomical. It's more physiological based in that particular patient. If whether you should be intervening LAD or not, given the angiographic appearance. Even if,
Devdatta, as such, your FFR will is likely to be positive with that amount of lesion or spasm, whatever we call it. With that amount.
post LAD, which what Rutin showed us after a few weeks. Looking at that LAD, I think without going for imaging anatomical, I would go for a functional and then see whether it's significant. Non-significant, so I won't do anything, regardless of what IMAS OCT shows. I think Mani, you will agree?
Devdatta, FFR will obviously be positive because you are not finding even 10-20% of luminous stenosis, I mean diameter stenosis in the post angiogram. But my point is, if you find such a significant stenosis, then if you are aware of the lesion present there, maybe that will guide your, I mean, reassessment of the patient in future. Maybe that will help you in deciding for PCSK9 or something else. So
No, that Mani, Devdatta, nothing will change the management of the patient, neither the FFR nor the IMAS or OCT. So what Rathinda did was actually best for the patient because the management is going to be same.
Because once you have ballooned that segment, you don't have any option. You have to put in a stent. Otherwise, you have already injured the intima. But my one question, one thing is coming.
No, sir, actually, I want to about
That
LAD.
is, no, I mean, I could understand you are talking about the LAD, but I have another view. Looking at the arteries, all the three are flowing arteries. So, this having this amount of hypotension, I think hypotension and other things were corrected by the time you are doing that angio. So, is it possible we don't do anything and send for bypass? Of course, I'm telling in retrospect. Obviously, this is not a prospective thing. I am telling in retrospect. Three flowing arteries and flow is TIMI 3. Even in RCA, the first shot, we had a TIMI 3 flow.
So that's what I earlier said, that if the patient is hemodynamically stable, you can leave the patient as such only and send the patient for CABG if patient requires it.
Then again, we'll be doing injustice to that patient because for a spasm, we will be doing a CABG.
Finally, injustice would have been done. Injustice would have been done. That's it.
You have an Achilles heel either way.
Sir,
Shumanta, yes.
Yes, I have a point, sir. I have a comment to make.
Shumanta একটা কথা বলছিল, something he was telling. Shumanta.
সুমন্ত স্যার মাইক্রোফোন মনে অন আছে, ওই এমনি আওয়াজ হচ্ছে।
Shumanta, you wanted to say something? Okay. Rothin, please.
Sir, as the patient presented with ST elevation, I will go for a primary, I will go for a PTCA, whatever the situation is. This is my I think guidelines also say that this is a similar kind of thing. Because as elevation, I'll have to address it because the patient is loaded in the emergency with either a particular or something like that. Because
Rothin, can you go back to the ECG once?
Yeah, okay.
Shuchit,
sir.
have a look at the ECG. Make it full screen.
এটা দেখলে তো obviously
when I speak in English, this is recorded.
I know. So I think by seeing this ECG,
don't have any. They have to go for no way. Though there is a concavity, but we see hundreds of inferior infarcts like this.
Yeah.
We see hundreds like this, so no question on that.
Sir, again sorry. Even though there is concavity, there is significant, as you only taught us, AVL significantly depressed.
AVL, everything. That's why I just like to have a relook. AVL is depressed. That shows that the current of injury is there, and that it is that this is the reverse of that thing. Everything is going towards that. The vectorial analysis, it is away from it. AVL. It's impossible
But
to
the
say that
correction, but the correction was also very good. Means after the procedure, it was almost like a
that
normal ECG.
actually,
That is something which is important.
yeah, that
As
was
pointed
really
out.
striking. Hardly there is any cue or anything, because
Yeah.
next ECG just post.
Yes, sir, I'm saying.
So there is another rare possibility of
Full screen.
Yeah, there is another rare possibility of simultaneous thrombotic occlusion of the two vessels of RCA as well
And
as
then
LAD.
where that LED thrombus has gone.
Yeah, yes, sir. LED thrombus can got spontaneously lysed also. There is a possibility. Many of the times we have seen that the
This
patient
is,
of anterior pulmonary comes to us and we find a recanalized LED.
No, that we do find on many occasions, but
Yeah, so it is quite possible that the LED thrombus had got autothrombolized, and we have stented the RCA. LCX lesion was also LCX lesion was present even
so
after.
you mean to say there is a thrombus in the 3 locations at a time? Theoretically possible, practically very,
Sir,
very
LCX
unusual.
LCX lesion was still present in the afterward images. LCX
No,
lesion has not.
no. LCX
No,
was
sir.
also dilated. It is not there. Ruthin can show the LCX after after staining. It's not there.
So also the EF, if the EF is 50% and all this thing with a severe critical triple vessel disease, this is also something which is abnormal.
The fact ECG normalized tells us two things. One, as we were suggesting, that it can be vasospasm induced and hence everything normalized. But in Ruthin's patient, if the patient was living next door, he came to us within half an hour. So it's difficult to differentiate from that normal ECG whether it was vasospasm induced or was it
very difficult. I say,
agree.
Very difficult. But anyway, the patient is good. That is the final thing.
I think to diagnose vasospastic angina, you have to provoke, but that is we are not doing, or we are not having those things.
Yeah.
Will we advise a stress test in this patient?
What kind of stress?
Now, I mean TMT or something to induce ischemia in the LAT territory.
No. It is not recommended to provoke a vasospasm by putting the patient in exercise. So if at all something is to be given, either
acetylcholine
or argonautin can be given to provoke this thing.
Little risky. It is very dangerous, risky. It sometimes produces so intense spasm it becomes problem.
Yeah, and as per the incidence of this thing, Japan is known to produce, but known to have some more proneness to develop spasm, and in some studies they have provoked acetylcholine routinely as atypical chest pain patients, and they have found up to 30% of patients having atypical chest pain to have vasospasm. So this is a quite high number of high percentage as per Japan is concerned. In France, it was around 10 to 12%. But apart from these other,
Ruthin, please unshare.
Okay,
unshare that.
Yeah.
You talk. No, you keep talking. Unshare the screen.
Yeah. So if at all something is to be done for provoking vasospasm, I think intravenous injections like acetylcholine or argonautin can be given, or even hyperventilation sometimes is known to produce vasospasm.
So anyway, has a wonderful case, and a wonderful deliberation. Both I'm using this adjective in both the cases. This type of case presentation is a very rather you see very rarely. And what Devdatta has done, he has given a very elaborate description of newer aspects of lipidology and what are the things to come. So he has improved our wisdom, and Ruthin has improved our experience. Thank you very much. Thanks both of you. And
Thank you.
We'll be meeting after 2 weeks again on a Sunday evening, same this time. And I will let you know who is going to present the case and who is going to present the topic or whatever is the program. I will let you know. So Till then, good night and goodbye.
Good night. Thank you, sir.
Good
Right,
night.
sir. Thank you, sir.
Yeah.